Hello and welcome everyone. My name is Kristen Talbot. I am the project manager for MAVEN, program manager for MAVEN Project. I gave myself a new title. And I'm going to welcome you all today to join us for today's session. Sorry, Tom, and my assistant is also here. Today's session, Topical Steroid Primer with Dr. Ginette Okoye. It is a pleasure for MAVEN Project to partner with Direct Relief, and just a little bit about each organization. MAVEN Project is a telehealth nonprofit that supports primary care providers working at safety net clinics across the country. Our experienced volunteer physicians offer provider-to-provider medical consults, one-on-one mentoring, and customized education sessions. Direct Relief is a nonprofit humanitarian medical assistance organization. Founded in 1948, Direct Relief supports the needs of healthcare providers and their patients worldwide. So with that, it is my pleasure to introduce our speaker, Dr. Ginette Okoye, who is a professor and chair of dermatology at Howard University College of Medicine. And we are just very lucky to have her as one of our speakers. So Dr. Okoye, when you're ready, please.
Thank you, Kristen, and good to be here again. It's always fun to see where people are from around the country, so continue to put that in the chat. I hope everybody's staying cool. It's a real heat wave where we are today. So today we're going to talk about topical steroids. You know, since I became a dermatologist, actually since in medical school, at the end of med school, when I declared an interest in dermatology, people started making fun of me and saying that steroids is, that's all dermatologists can prescribe. So that's not true, and I'll show you why, but it means that we are really experts in topical steroids. So I thought this would be a nice topic for you guys, because I want you to go from kind of topical steroids 101 to being very comfortable with them and really thinking about some of the nuance that can make your prescriptions more effective and help your patients adhere to them better. These are my disclosures. None are necessarily relevant to today's presentation. And just a reminder, you can get one CME credit for this hour presentation. So what we'll cover today is we're going to go through some of the basics of like the science of absorption of topical medications into the skin, because I really want you to understand what you're prescribing and why. And then we'll go through some of the vehicles that topical steroids come in, and we'll talk about how they're different and how they can be used differently to be more effective in different parts of the body. And then, because whenever we think about topical steroids, we always should also think about steroid-sparing drugs. We're going to talk about some of the calcineurin inhibitors, because regardless of what you're prescribing a topical steroid for, if it is a chronic condition, you do eventually want to transition away from the topical steroids on a daily basis to a topical steroid-sparing agent. So I included a little bit of that at the end. So this is a portion of the dermatology toolkit. Partly, I wanted to show you this because you can see that many of our medications are topical, so we have to build some expertise in how these things work, and I want to share that with you. But also to show you that we have this huge toolkit in dermatology, and if you are interested in learning about how to manage patients with any of these in this toolkit, please let us know so that I can tailor some more kind of therapeutics lectures to you as the next year or two go on. So here are some things to think about when you're thinking about choosing a topical steroid for your patient. You know, eczema, psoriasis, seborrheic dermatitis, whatever inflammatory condition you're trying to treat. If you're thinking, okay, baseline 101, you're really thinking about, okay, what strength am I prescribing? Another way to say that is, what's the concentration or the dose of medicine that I'm trying to give? And then you also want to think about, where's the patient going to be applying it? It's very different to apply a topical steroid on your palm compared to your eyelid, right? You're going to choose a very different steroid in those two situations. So basic 101 steroid prescriptions, we need to talk about that. But I want you guys to go to 201. And my experience with this group is that you've generally mastered 101 dermatology stuff. And so I really like to take you a little bit deeper. You want to maximize absorption, right? So there are some hints and tips and tricks I'm going to show you to maximize that percutaneous absorption of your prescription. And then you want to choose the right vehicle for the right location and for the right application. And all of this will help you improve your patient adherence. So let's talk a little bit about percutaneous absorption, or PCA. So basically, the more of your steroid that's absorbed, the more effective it's going to be. And there are multiple ways that that can happen. It depends on the actual molecule. Some drugs will go directly through the epidermis, through the cells in the epidermis. Some will go between the cells in the epidermis down to the dermis. And others will actually go down the hair follicle or down the sweat gland here, as you see in this cartoon. And so these are all the ways that medicines can work their way through the skin. And so it makes sense, if you think about it, if you have a hair-bearing area, right? Let's say the chest. The absorption of your steroid is actually going to be higher because you have more opportunities for that trans hair or transappendigeal absorption to occur, versus an area like the palm, where you don't have a lot of hair follicles. It's harder for the medicine to make its way through. There's some other reasons it's hard for topical medications to make their way through the palm, which is the skin there is thicker, right? The stratum corneum, that top layer, is much thicker and harder for the medicine to penetrate. So, I wanted this to be a little bit more interactive today. It's so hot, everybody's a little bit lethargic, so I thought I'd wake you guys up. Tell me in the chat, some of you, what do you think are factors that might affect percutaneous absorption? So I gave you one just now, which is like the thickness of the skin. Right? So like the palms, the soles, those will be harder for topicals to penetrate. Or even if you have a rash where you have hyperkeratosis and the layers of the skin are piling up from the rash, like thick psoriasis, that's harder for your medicines to penetrate. So John is saying how long you rub it in. Well, John, I guess perhaps by rubbing it in, you're going to increase the temperature of the skin, and that might help with percutaneous absorption. Linda is saying the vehicle you choose. Yes, and we're going to talk about that. Angela says the type of skin. Yes. So, for example, mucosal skin. So let's say the lip, the genitals, the skin there is literally thinner. So it's going to be much easier for drugs to penetrate. And actually, the part of the body where you get the highest percutaneous absorption is the scrotum, because it has not just that the skin is thinner there, but it has a big surface area because of the irregularities in the skin, and it has hair. So if you're putting a topical steroid on a scrotum, you have to go with the lowest strength that you possibly can, or maybe avoid steroids in that area. Jermaine said the age of the patient. That's right, pediatric versus geriatric, because in our pediatric patients, the surface area to volume ratio is different. So if you put in the same anatomic area, the same medicine in a child and an adult, the child will absorb more. John, good one. After a shower. Why is that? Yes, hydration. So if the skin is moist, it's going to improve absorption of topical steroids. Oh my gosh, see, you guys don't need this lecture, you know already. I love this. Jennifer says occlusive dressing. Yes, occlusion of any sort, whether it's with a dressing or even skin on skin, right? So if you put a topical steroid in the underarm and that area is always occluded because the skin is rubbing on skin, that will also increase the absorption. Well done. Thank you guys so much for playing along. So let's see, I think we got them all. So the vehicle, I listed the really important ones here. The vehicle is super important, and we'll talk about that. Ointments generally have better absorption than creams, which generally have better absorption than solutions. And we'll talk about what the actual difference is between those three. The concentration of the drug, I don't think we got to that one. But that makes sense. If you have a 0.1% triamcinolone and a 0.5% triamcinolone, you're going to get more absorption, or at least you're going to get more drug with even the same amount of absorption if you use the higher concentration. We talked about the thickness of the stratum corneum. Hydration or moisture in the skin absolutely helps with penetration. We talked about occlusion, whether that's with a dressing, or sometimes we'll have patients use plastic wrap, or we'll have patients use like a nitrile glove to help with that occlusion. But remember, skin on skin occlusion in like the groin or under the breast, that also counts for occlusion. And then the disease itself. So if the skin is broken, right, if the skin barrier, the epidermal barrier is broken, then the drug doesn't have that far to travel to get absorbed into the skin. So inflamed skin, when your skin is inflamed, there's a lot of blood supply to that area, and that can help with absorption as well. Ulcerations, basically you're putting the medicine right into the dermis. So when you think about what you're seeing on the patient, if they have eroded or open skin, they're going to get more medicine absorbed. And then some other factors just to think about. Now, this is kind of the 301, but I think you're ready for this because you got most of the 201 level of percutaneous absorption. The actual size, the kind of chemical structure of the drug makes a difference. So, for example, when we talk about the calcineurin inhibitors, we'll talk about tacrolimus ointment. Well, there's some concerns with the FDA black box warning with tacrolimus, but tacrolimus is a huge molecule. It cannot penetrate that well in the skin to the point where it can increase levels of tacrolimus in the blood to any appreciable amount. So the actual molecular weight, the actual chemical structure of the drug makes a difference. If the drug is lipophilic, right? So if the chemical structure of the drug means that it likes to attach to fat molecules and lipids, it will attach to the lipids in between the cells of the epidermis, and that will help its passage through the epidermis. If a topical steroid is in and of itself irritating, that irritancy also increases penetration because the irritant property will break up the barrier of the skin a little, which will allow it passage, and it'll bring blood supply to vasodilation in that area, which will help kind of carry some of the medication throughout the skin. And we use this sometimes. So an example of this is a gel. If you use a topical steroid in a gel form, gels and some solutions are alcohol-based or they have propylene glycol, and that can cause some irritation. So, they can also cause some symptoms like stinging and burning, but sometimes we'll use the gel formulation because we know we're going to get better efficacy quickly in certain situations. Another place where we use irritancy is with topical tretinoin when we treat acne. Tretinoin is irritating. And because it irritates the skin and it dries the skin out, it actually helps itself to penetrate and work better. We talked a little bit about surface area to volume ratio, which affects, it causes increased absorption in smaller people, like kids. And then I hinted at this idea of vascularity. So if you have vascularity because the skin is irritated, that will increase absorption. But also if you have a part of the body that simply has more vascularity, like the face, the lips, the genitals, so these areas just have a more robust blood supply, and so you're going to get more absorption there. And then we already talked about locations. So let's talk about the vehicles, right? This is a really important part, I think, of getting the nuance down. So we have ointments, we have creams, we have gels, and then we have lotions and solutions. All topical steroids, not all topical steroids have one of each, but many do. So what is an ointment? An ointment is basically water in oil. So it's more oily, it's more greasy. A cream is oil in water. So it's more creamy, it's easier to apply, and people tend to like creams a little bit better than ointments. Not everybody, but some people love ointments. And then gels, it's basically an emulsion in an alcohol base, as I mentioned before. So it could be a little drying, a little irritating, but sometimes you have a part of the body that's moist, let's say under the breast. It's not as fun to put an ointment under a breast, right? It's greasy. The patient is going to be a little uncomfortable. They're going to feel hot. They might sweat more. They might get a candida infection. Well, that might be a part of the body that you're willing to use a gel, because then that will have some drying properties and that will help the patient in multiple ways. And then we have lotions and solutions. They're basically like the powder form of the drug in oil or in alcohol, so they can vary. And you can see here the potency differs. Ointments are stronger than creams. Gels are very strong, remember, because of that irritancy tendency. And then lotions and solutions tend to be on the lower potency side, even if it's the same medicine. So triamcinolone 0.1% ointment is literally stronger than triamcinolone 0.1% lotion. Okay. If that solution is in alcohol, that isn't true. If it's in alcohol, it is stronger. And then it goes without saying that an ointment and a cream, they will contribute to hydration of the epidermis. And remember, we said that hydration helps penetration. So that may be one of the reasons why ointments are more effective. The other reason is because the ointment literally occludes itself, right? We talked about occlusion with with a plastic wrap or Band-Aids. Well, an ointment is literally forming a film over your skin, so it helps to occlude the topical steroid. We talked about the fact that gels are drying, which can be a good thing if used in the right setting. And then this is interesting. You know, often we're telling patients, don't worry, the generic is generally the same as the brand name. Well, in the topical steroid world, that's actually not the case. There's actually a good bit of variability between a brand name and a generic topical steroid cream, gel, solution, or lotion. Doesn't matter to me, frankly, because my patients can't get any brand name anything. So we've just figured out which of the generics works well, and if it doesn't work, we'll switch it off. I think they work just fine. But this, just for your information, it is true that if for any reason a patient says, oh, I have been using Vanos, this doesn't exist anymore, so I think it's okay to say it in a CME setting. I've been using Vanos ointment, which is fluocinolone, and you give them fluocinolone generic, it may not work as well to the patient, and that might actually be true. We talked about the irritancy risk. So ointments and creams tend not to irritate at all. And especially in somebody who might be prone to allergies or their skin is really sensitive, then you really want to stick with an ointment, because the risk of developing an allergy to topical steroids, which is a thing, it does exist. You want to use an ointment, because the ointment is basically petrolatum and the drug. Creams, you have the drug, and then you have things that stabilize it in cream form and propylene glycol. You might have fragrance. Like the creams have a lot more ingredients, including formaldehyde, quaternarium. These are preservatives. So there's a reasonable risk of contact allergy with creams. So ointments are great. The only thing about, so clearly I have a bias, right? I think ointments are better, but patients may not like them because they can be greasy. Creams, patients accept them really well. And so sometimes, even though I might want to use an ointment, I may start with a cream just to make sure that the patient is happy and that they'll use it. And if it's not effective, they know that the ointment might be the next option. Patients tend to like lotions and solutions as well. Again, they're not greasy. And then there are certain parts of the body where they would work better than others. And we'll go through some cases here with that. So let's see, let's get you guys back active in the chat here. So here's a patient with scalp psoriasis. So this is an African-American patient with curly hair, and that kind of becomes important here. What vehicle would you choose? I think the best thing is to ask patients, right? So you want to explain to them the difference. This is an ointment, which is kind of greasy. This is a cream that'll rub in. This is a gel, alcohol-based. I just give them a little spiel and then let them choose. But let's say you were going to choose for this patient. What would you think? What would you prefer? Ointment, cream, gel? solution, lotion. Anybody? Angela said gel. Okay. Okay, I'm seeing a gel, solution, lotion. So when it comes to the scalp, okay, most people are thinking more of the not creams or ointments, so gel, solution, lotion. When it comes to the scalp, in someone with curly hair, in general, an ointment might be preferred, and this is where you have to ask the patient. The reason being, and I'll show you, I think I have another, hold on one second. Yeah. So like this patient with straight hair, more than likely, they will prefer a solution, a gel, because it's alcohol-based. It's going to go onto the scalp and then it's going to dry very quickly. Because if you have straight hair, then if you use something that's an ointment or a cream, your hair is gonna, the oils from that product is gonna make its way down your hair shaft very quickly and your hair will be oily and limp. But in people with curly hair, the hair itself is drier just by nature. And I have a hair lecture, we could repeat that sometime this year if you like. But the hair itself is drier. And so if you use something with an alcohol base, it's going to cause more dryness on the hair shaft itself, which might lead to hair breakage. Additionally, just kind of like culturally, people with curly hair of African descent are kind of used to applying ointment-like preparations on their scalp. It's called greasing your scalp. So it's not a foreign concept to them. So again, you don't want to make any assumptions here, but in general, this is true. And if you have a Black patient who wears their hair straight, then the same thing applies, right? Where their hair is straight, even though they're Black, if they put on ointment, their hair is going to be limp and they may not use it because it might ruin their hairstyle. So good. Thank you for those of you who jumped in the chat. How about this one? What vehicle do you want to use? Okay, Crystal said, oh, everybody has a different opinion here. Cream, lotion, gel. I don't think there's a wrong or a right answer here. I would probably, it doesn't look irritated to me. You know, this is psoriasis. It doesn't look eroded. I don't see any open skin. This might be somebody who I would try on a gel, or if I could get it through insurance, or maybe a solution, because it's dry and so under the breast won't be wet and goopy and sweaty. If not, let's say they try the gel and it burns, because it might, then I would try a cream or a lotion. And if that doesn't work, then I would go to an ointment. I actually probably would never use an ointment here. Why? Because it's occluded, it's skin on skin. So even a mild steroid ointment is going to be very strong in this area. So I would do a cream. Again, no right answer for this one. I think some of it is trial and error, but just thinking about who's in front of you and what you would use. I think was it Linda asked if I'm asking about topical steroid? Yes, I know this kind of looks like candidiasis. You're like, why would we put a steroid on candidiasis? But this patient actually has inverse psoriasis, and the clue is here. These little guttate psoriasis lesions here. But yeah, it does look like candida. So thank you for the clarification there. All right, one more. How about this one? Could be one of a couple answers here, I think. Which vehicle? This is lichen planus on the lip. So Sandia is saying a gel. I think a gel could work here. It's going to work really fast too, because remember the gel is stronger. It's already on a mucosal area, and there's a lot of blood supply on the lip. So you might get away with just applying this a couple times a day for 1 week and get a lot of efficacy. Ointment is also a good option. Why? Because the ointment will stick. Because the problem with the mouth is you're eating, you're talking, you might be licking your lips. And so medicine doesn't stick around very long. The nice thing about a gel or a solution, because it's alcohol-based, you put it on, it absorbs, and the rest evaporates, they're good to go. But an ointment will kind of do the same thing. It'll stick around a little bit longer. And again, patients are kind of used to some patients are used to putting something greasy on their lips, so they may not mind their lip being all greasy and shiny. So very good, very good. Thank you, guys. All right. How about this one? Last exercise here. This is a patient with, this is hand eczema. Remember, this is the palm, thick stratum corneum. What would you use? I see ointment here. Yes, ointment. Yeah, most people are thinking ointment in this case. Yeah, we really need that high potency in that situation. I would have him soak his hands for a little bit in water to get that hydration going, then apply the topical steroid ointment, and then maybe some nitrile gloves to help with that occlusion. So it's like a 1, 2, 3 punch. The downside is most people do not want to put an ointment on their hands. If they're working with paper or they're working on a computer, can you imagine? It's like greasy. And so as much as I want to give ointments all the time for palms, sometimes I'll give them both. I give them the cream to use during the day and the ointment to use, when they get home or at bedtime. And the thing about the palms, it's really hard to keep medicine on your hands. You're washing your hands, you're touching things, you're driving, and the medicine's wiping off. So patients can actually apply topical steroids on their hands 3, 4, 5 times a day. They can do it more often so that they can get more contact time. I'll actually tell some people, okay, why don't you apply your clobetasol ointment with a nitrile glove on your way in to work or school. And then when you get there, go ahead and take the gloves off. You could wash your hands, maybe put a little bit of cream on, and then go through your day. And then when you're going home, same thing. So they're getting at least a few hours of high contact and occlusion. All right, so let's get into some of the specific topical steroids now. All right, we kind of went through this, right? We talked about the vehicle, we talked about the potency, but the other thing that you and I have to think about is the price and whether or not that topical steroid is on the patient's formulary. So basically, that's how I choose. And then I think another thing you have to think about is how much to dispense. The thing that I see the most is patients get too little of the steroid because we're worried about, potential side effects. But I actually think it's okay to give them a good bit of medication that they can actually make sure they use the right amount. Because if you give a patient like this, so this patient has really bad psoriasis. And when he came to see me, this is what he had. This is what had been prescribed to him, a small tube of triamcinolone. 1, the potency is too low, and 2, it's such a little bit that where was he going to apply it? He basically picked a spot and was applying it twice a day. And then patients tend to use too little of the medicine because they're trying to make it stretch. So really look at how much involvement the patient has and give them the right amount of medicine for the job so that they can apply it twice a day for 2 full weeks. So in this case, this situation, he needed at least a 454-gram tub, a big tub of triamcinolone. Most people are not going to get into trouble with 1 tub of triamcinolone. All right. So when you're thinking about the steroid itself, like which one? Do we do hydrocortisone, triamcinolone, fluocinamide, etc.? It depends. The strength of that steroid depends on the actual structure of the steroid molecule. So the stronger steroids have a chlorine molecule attached to them. So that's like clobetasol, halobetazol, and those tend to be more potent. We talked already about the vehicle. And then the actual concentration of the drug. right? So when it comes to the vehicle, we know that, let's say, fluocinolone, 0.05% ointment versus cream, the ointment is stronger, but triamcinolone exists in multiple strengths. So you have triamcinolone 0.1%, 0.5%, 0.025%, and they are not the same, right? The 0.5% is going to be much stronger than the 0.1%. So, if you're in your EMR, you're not like selecting carefully, you might give a patient 0.025% triamcinolone. And that's about the same as a hydrocortisone, 2.5%, maybe less. And that may not be what you were trying to achieve. You wanted something stronger. Or worse, you wanted to give someone 0.1% triamcinolone and you pick 0.5% by mistake. Now they have very high potency steroid that you didn't mean to give them. So really be careful with the concentrations. And then we've been talking about this right throughout. The potency of your steroid depends on the skin that you're applying it to, where it is, and how inflamed and irritated it is. So this big busy slide now, if you leave with nothing else, just remember that ointment. If you could get the patient to use an ointment, you're going to be in good shape because it's stronger, less likely to irritate them. But most people like creams. I like this chart because I think there's so many topical steroids out there. It's easy to get overwhelmed. I would say just pick one or two from each of these classes and just get comfortable prescribing that one. So, our steroids are listed by class. So from class 1 to class 7, class 1 being the strongest steroids we have, like clobetasol and halobetazol. And then class 7 are basically your over-the-counter hydrocortisone 1%. And so, again, you could see this triamcinolone 0.1% lotion is a class 5, which is, relatively low potency versus your triamcinolone 0.1% cream is a class higher, and your triamcinolone ointment is, even a class higher than that. So, just pick your go-tos from there. There's some really nice comprehensive lists online. If you do topical steroid classes, there you can see all of the classes and you can look at your formulary or the most common formularies in your area, and you just pick one or two from each class that you prefer to prescribe. These are my favorites. When I need a low potency steroid, I love hydrocortisone 2.5%. When I want something medium potency, triamcinolone 0.1%. High potency, I like fluocinolone 0.05%. And then when I need something really strong, I go for clobetasol. And these are generally well covered by public insurance, which is what most of my patients have. The clobetasol, we've been having some trouble recently where patients are getting denied their clobetasol or we're being asked for prior authorization. So that's new. So I've been doing more halobetazol in that situation. So we can't talk about topical steroids without talking about the thing that everybody worries about, which are the side effects. So, overuse. So overuse is the key of topical steroids, can cause thinning of the skin, can cause stretch marks, hypopigmentation, and that takes a while to develop. So if you prescribe a steroid for someone to use twice a day for 2 weeks, even 3 weeks, 4 weeks, that's not going to cause these side effects. It's really prolonged use, except in situations, let's say you use a clobetasol under the breast, right? It's going to be occluded by this skin on skin. That may take 2 or 3 weeks to develop some atrophy and some hypopigmentation because it's just the wrong steroid in the wrong place. But if you pick the right vehicle and you pick the right strength, you're not going to hurt your patient if you're giving them a topical steroid. Steroid acne, patients can get basically these monomorphic papules, especially on the face, but it can happen on the trunk as well, again, with prolonged use of steroids. And then perioral dermatitis, which is basically a form of rosacea. That can happen. That's kind of idiosyncratic. You don't need a strong topical steroid to develop perioral dermatitis. As a matter of fact, most of the people who I see develop perioral dermatitis from steroids, it's hydrocortisone. So that one you can't necessarily predict. But if you have been using a topical steroid on a patient, let's say for seborrheic dermatitis in the nasolabial fold, and they come in and they have all of these fine papules, almost like acne on the lower face, around the mouth or around the eyes, it's the steroid that did that. And really, there's no way to know who that's going to impact. So that's the patient that I would switch to like a topical calcineurin inhibitor. Again, though, I would say even in perioral dermatitis, even though it can happen in low potency steroids, it's usually prolonged use. I haven't seen this happen very quickly, using a steroid for a couple of weeks. I've seen it in people who have been using steroids off and on for a while. And then topical steroid withdrawal. Patients are very concerned about this. There's a kind of a big community online talking about topical steroid withdrawal, almost like as a syndrome. I think this is just a form of tachyphylaxis. So basically in tachyphylaxis, especially if you're using the high potency topical steroids in the long term, over time, you need more and more medicine to get the same effect. And so that is a real thing. And again, it happens with chronic use. But the thing with the topical steroid withdrawal, for some patients, when they stop the steroid, they get this like redness and burning and itching. It's almost like a reactive hyperemia. And we think that's from the blood vessels in the area sort of changing their behavior because of the steroids. And then when you withdraw it, it kind of dilates and behaves badly until your body can figure it out. So it is a real thing. Like there are definitely people who, if they use steroids for months and months, when it's time to stop, they have a really hard time getting off it. But again, that's not with proper use. That's with overuse. And where I see this often is patients with really bad eczema who really should be on a systemic medicine, right? They should be treated. The steroid is not the right treatment for them, because if you need to use a steroid twice a day, every day for 6 months, then we're using the wrong medicine. It's not working for you. So even though I just said all those things, I don't want you to be afraid to use topical steroids. In my opinion, it is better to use a stronger topical steroid for 2 weeks, twice a day, knock the inflammation out, and then you can kind of peel back. So I would do twice a day for 2 weeks, and then I would peel back to just weekends only for maintenance. And that is better than using a weak steroid because you're worried about side effects. So you pick a weaker steroid, and then the patient has to be on it for longer to get the same effect. So I hope that makes sense. If you have somebody with, let's say, poison ivy, and you give them hydrocortisone 2.5%, it's not really going to touch it. It's going to take them weeks to feel better. But if you give them some clobetasol twice a day for 2 weeks, or twice a day for even 4 weeks, they're not going to get stretch marks. They're not going to get atrophy. What they will get is relief. And then after your 2 to 4 weeks, you're going to be able to stop the steroids, whereas they would be on hydrocortisone for months trying to feel better. So here are some of the, side effects from long-term use of steroids. You can see the thinning of the skin here, the atrophy. You could see her vasculature. You could even see the subcutaneous fat here, and then it got so thin it eroded. Again, that's the breast, right? So this is an area of occlusion. So if she got a strong steroid here and she had occlusion from skin to skin, I could see why that could happen in this area. Here's a nice example of that perioral dermatitis I was talking about, this rosacea-like rash from long-term steroid use. And then this is more subtle, but this is, again, some hypopigmentation from the steroid. And actually, sometimes in the disorders of hyperpigmentation, we actually use steroids for this potential side effect. We want some hypopigmentation to happen in some cases, but you can see the atrophy because you can really see this patient's blood vessels showing through here. So just some practical tips for using topical steroids safely. I would say just start with 2 weeks. So twice a day for 2 weeks. So you give them enough medicine to be able to do that. There are definitely some situations where I tell patients it's okay to do it for 4 weeks because I know it's not going to hurt them. But it might be severe enough or itchy enough where they may need more time. For long-term use, so let's say it's someone with a stubborn patch of eczema. They're otherwise well controlled, but they have this stubborn patch on the back of their leg or something. Then after we do the 2 weeks, I'll tell them do every other day for 2 more weeks. And then just on weekends. So every week they're getting a little boost of the steroid, but they're not using it every day. Once you start breaking up the daily use of topical steroids, your risk of side effects goes way down. Using a steroid every other day, you are not going to get into a lot of trouble. Certainly if you're just using it on the weekends. And then we talked about occluding steroids. So I like to use plastic wrap, transparent dressings like Tegaderm. So if you have a specific spot, you apply the steroid, you apply the Tegaderm, that's going to help with occlusion. Even Band-Aids will occlude. So don't hesitate to suggest those to patients. And then we have these things called soak and smear, where you're really using that hydration from a bath or a shower. And I'll tell you, I'll go through the details of the soak and smear. And then ask patient what vehicle they prefer. And you explain to them the differences so that you can give them something that they'll actually use. So for special sites, like those occluded areas with skin-on-skin contact and the genitals, the diaper area in children and so on, I would use a low-potency steroid. That's where I would use a hydrocortisone 2.5%, and I might use it for 1 week and then take a look to see how they're doing. Definitely no more than 2 weeks. Or in some of these situations, I'll just skip the steroid and go to a steroid-sparing agent. We talked about these areas that have a lot of percutaneous absorption just naturally because of, maybe it's hair bearing or it's mucosal. So like the eyelid, the labia, the scrotum. These are places where I might skip the steroid altogether because they're going to get a lot of absorption even when I use a low potency steroid. And then the scalp is another special site. We touched on this before. This time it's more about the vehicle, and you can get away with very strong topical steroids on the scalp. You are not going to thin the skin on the scalp. So don't hesitate to give somebody clobetasol or fluocinolone for their scalp, for let's say their seborrheic dermatitis or their alopecia, or psoriasis. Go strong because they're going to need that level on the scalp, and it's really not gonna hurt them. There's a really nice oil. There's one steroid oil that's out on the market called fluocinolone. Fluocinolone, if you remember from that chart, is a class 5 or so. So it's like a medium to low potency steroid. And that comes in a scalp oil. And so patients can apply that to their scalp. And the box says apply to the scalp overnight and then shampoo out in the morning. That's okay for people who shampoo their hair every day. But in patients who don't shampoo their hair every day, they can just apply it as though they're greasing their scalp every day. And that tends to help seborrheic dermatitis really well. Okay, so let's move on to the steroid sparing agents. I won't talk too much about crisaborole. Is a non-steroidal anti-inflammatory. Honestly, I just don't think it works that well. Plus, it burns a lot. Patients always complain, and it's still brand name, so I just can't get it for my patients. So we won't talk much about that one. And then there's a topical vitamin D analog called calcipotriene. That's an oldie but goodie. It's really good for psoriasis. So this is a cream where I would use it. Let's say the patient, I give them a topical steroid. They'll use it twice a day, Monday to Friday. Twice a day for 2 weeks. Then I'll have them switch to calcipotriene Monday to Friday and the steroid on the weekends. That's a great regimen for psoriasis. And you're not going to get side effects from the topical steroids that way. All right, but let's talk about the calcineurin inhibitors. So these are FDA approved for the treatment of eczema, but we use them in lots of other things like vitiligo, psoriasis, seborrheic dermatitis. It's harder to get them covered for those other indications. And you have tacrolimus, which is the ointment form, and then you have pimecrolimus, which is the cream form. My concern with these drugs is it always requires a prior authorization. And so one way to help your prior authorization is these things that I bolded here. You want to make sure they are in your note. So moderate to severe eczema, that's what it's indicated for. So that needs to be somewhere in your note. And you have to say that the patient has failed another topical medicine for eczema, or it's not appropriate for them to use another topical medicine, which is basically a steroid. So you can say, this is the eyelid, and therefore I do not want to give this patient a topical steroid. I'm prescribing them tacrolimus instead. And just FYI, it's not approved for children under 2, so it won't be covered. You won't get a prior auth approved for them. They're great. These are great for maintenance therapy. They spare your steroids, right? So you can use your steroid on the weekend and use these Monday to Friday. They're not as good for severe flares of anything, eczema, psoriasis, anything. If the patient's flaring, give them 2 weeks of steroids, then transition to your tacrolimus or pimecrolimus. Both of them can cause a stinging or burning sensation in the first few days. So just give patients a heads up. And usually if they push through that, that sensation goes away. I think tacrolimus is more effective, makes sense. It is an ointment, but pimecrolimus it's nice. It's a cream. So for on the face, I tend to use that more regularly on the face. They come with this black box warning that gets people really worried. And we use this quite a bit in children, so it gets the parents really worried because it says that there's a potential link to malignancy, specifically lymphoma. But the large population-based studies haven't shown an increased cancer risk with use of these drugs, and we've been using them for 20, 25 years. And the absorption into the skin is really minimal. From the skin into the circulation is minimal because we talked about the size of the molecule, right? This is a really big molecule. It just doesn't make it into the blood in enough concentration to cause any problems, except, if the skin is eroded and irritated, you'll get a little bit more absorption that way. But still, even in patients with severe skin disease, there is not been a link between cancer and TCIs. But I talk about this ahead of time. The last thing I want to do is to prescribe this medicine and the patient or the parent goes to pick it up and they see this black box warning, the pharmacist tells them about it, and I didn't kind of give them a heads up and give more education. Really important. I'm just sharing the Washington, D.C. Formulary here. I have the Medicaid formulary here with you just so you could see. It really helps to look at your formulary because remember I was telling you about that oil, fluocinolone oil, which is great for seborrheic dermatitis in people with that curly hair. Well, this is the brand name for it. And the brand name is preferred. So I can get the brand name of this without a prior authorization, but if I do the generic, I need a prior auth. Who knew? So just check your formulary just to make your life a little bit easier. And you can see here, same thing with the topical calcineurin inhibitors. If I write for tacrolimus ointment or pimecrolimus, I need a prior authorization. But for some reason, the pimecrolimus brand name, they'll pay for, which is interesting. But helps my staff to just do what we're told. Okay, just a couple of cases to close us out here. This is a patient with psoriasis. But if you look at the psoriasis, it's really thick. It's really hyperkeratotic. So of course we're thinking, all right, we probably need an ointment in this patient because we need more penetration. It's more severe. But more importantly, nothing is going to really penetrate this level of hyperkeratosis very well. So you need in this patient to actually also deal with the keratosis. So you want to use a keratolytic. A really common keratolytic is salicylic acid. So you can get salicylic acid acne wash over the counter, and the patient can use that almost like a body wash in that area. Over time, it breaks down that hyperkeratosis and allows the steroid to penetrate. Ammonium lactate cream or amlactin is another nice keratolytic. So they can apply the ammonium lactate a couple times a day, and then they can apply their steroid twice a day. They can even apply them one on top of the other, and that will help with penetration. This is somebody who I would go straight to clobetasol, twice a day, 2 to 3 weeks. If they insist they don't want an ointment, then I'll give them the cream. And then I'll tell them right out of the shower, don't dry the skin in that area, apply the ointment, preferably while the skin is wet. So you're really trying to maximize everything for this patient because it's going to be tough to get this treated topically. This is a patient who probably needs systemic medications eventually. You saw this picture before. This was someone we talked about, well, maybe a solution would be nice for this person because she has straight hair. But again, here's that thick hyperkeratotic plaque. So this is a patient who I would have them buy salicylic acid shampoo over the counter. It's 3% over the counter. Lots of different brands have one. And then I would go strong, clobetasol or fluocinamide solution in this case. And here's another hand dermatitis. But what's nice about this person's hand dermatitis is not very thick, but it is pretty extensive. And we talked about the fact that it's just hard to keep medicine on the hands for people who are busy doing things throughout the day. So they can apply it 3 times a day, 4 times a day if they need to. And then this person, I would say, use an ointment and get them to wear nitrile gloves at least once a day for a couple of hours to increase that penetration. And I would go straight to clobetasol, do not pass go. Look how red this is, how inflamed it is, and probably super symptomatic. Go strong, twice a day, 2 weeks, 3 weeks. You're not going to hurt them. You're going to give them good relief. And then finally, this is a patient with pretty severe eczema on the trunk, so on the back and on the chest. You have a large body surface area. They're super itchy. They probably need systemic medication, but at the very least, you want to give them enough medicine to cover all of the areas that are affected. And then this is a nice patient to do the soak and smear technique. So basically, you tell them to get into a bath or take a nice warm shower. And when they get out, don't dry their skin. Apply the ointment to wet skin. Then put on some pajamas, and that helps to occlude and go to bed. You'd be surprised. It works so well. Sometimes 1 or 2 days of that, it really calms things down, especially for kids. We use this a lot for eczema in children. It works really, really well. All right, and with that, I will end, and I think we have a few minutes for questions. Let me see. I think I see a few in the chat here. So Linda is asking, what about topical steroid use on the face? Sometimes hydrocortisone is not effective. Well, Linda, I rarely go above hydrocortisone 2.5% on the face. If hydrocortisone 2.5% on the face twice a day for 2 weeks didn't work, then I'm reassessing what I'm looking at. And whether it be eczema, psoriasis, sebderm, that should work. The face has relatively thinner skin. It has a lot of blood supply, and that is as strong as I would go on the face, except in one situation, which is vitiligo. In vitiligo, clobetasol, do not pass go clobetasol, because you need that level of anti-inflammatory to chase the immune system away from the skin in that area. So that's the only time I would put anything but hydrocortisone on the face, to be honest. So LSNA, so lichen sclerosis in the labia, that is the second time when I would break my rule and do clobetasol. So vitiligo, lichen sclerosis, they get clobetasol immediately because studies have shown that that's the level of anti-inflammatory that we need. Thank you for that question. And the thing about lichen sclerosis in the genital area is we know that if we let that inflammation keep going, one, it's going to cause distortion of the anatomy and all the problems that can come with that. And two, untreated lichen sclerosis it puts the patient at risk for squamous cell carcinoma development from the chronic inflammation. So this is a time when you put aside your fear of the thinning of the skin, because the thinning of the skin is the least of your worries when it comes to lichen sclerosis. Thank you, Linda, for those questions. Jermaine is asking, do you ever recommend cotton gloves while sleeping? I don't, because I figure the cotton is going to absorb some of my medication. So that's why I like the nitrile gloves, because I think they don't absorb the medicine. They just really form a nice seal. But yes, I think most patients, they try cotton gloves first because they can easily find that information. But yeah, so that's why I don't use it. But I do have colleagues who like that. And let's see. I saw someone says, I have a patient with, oh, sorry, it's jumping around here. Patient with perioral derm from hydrocortisone who I put on clindamycin. Should he discontinue the hydrocortisone he's using for the sebderm? Yes, the first line of treatment for perioral dermatitis that was caused by a steroid is to discontinue the steroid. But you have to wean them off a little, because it's like the skin is addicted to the steroid. When they stop it, the perioral derm will flare, and then they'll put the steroid on again, and it'll get better. And so the patient gets into this vicious cycle. So what I would do is I would prescribe either pimecrolimus or tacrolimus and have them start to alternate. Hydrocortisone on one day, pimecrolimus on the other, and just alternate like that for a couple of weeks. Then skip 2 days, then skip 3 days, if you know what I mean. Just kind of wean them off the steroid until they're treating the seborrheic dermatitis with the pimecrolimus or tacrolimus alone. And honestly, for perioral dermatitis, most patients need doxycycline oral, 100 milligrams twice a day for anywhere from 1 to 3 months to really get quick resolution. So that's what I would recommend. John says he has a question about soak and smear. John, do you want to unmute to ask? I see your hand.
I will.
A wonderful lecture as always, Dr. Okoye. I always learn so much. You and I went to the same medical school, you remember, and I had a teacher many years before you, unfortunately, who was really a nut about soak and smear. So that's why I put rub it in well, because he told me that so many patients just put the cream on and just leave it there, rub it in. So he always said 30 seconds at least. So that's why I put that in.
That's great. We probably had the same teacher. So I think the creams, you're right. I think some patients, they put the cream on. If you can still see cream on the skin, you're right. It hasn't been rubbed in, and then that cream can get rubbed off, and then they don't get as much. So yes, that does make sense.
How long should you make them go around in circles to try to rub it in?
I say until if it's cream, because the cream will be white, once the white is gone, once it's, yeah.
Okay. That makes much more sense. That's great. Thank you so much.
You're welcome. All right, I think, let's see, Thomas Scott, can you explain the physiologic process of the macules of hypopigmentation on Latino children? Is temporary, but yes, patients always concerned. So especially if you're speaking about hypopigmented macules on the face, that's likely pityriasis alba, which is basically eczema on the face, a really mild form of eczema. And so in the summer, the rest of the skin tans, but the little spots don't tan. They do great with tacrolimus or pimecrolimus, or even just moisturization. And Shakir is asking, do you recommend maintenance therapy for LS? So I think you mean lichen sclerosis. Yes, so in lichen sclerosis, I tend to do clobetasol once or twice a day for about 4 weeks, or until they're not symptomatic. So if at 4 weeks they're still having itching or burning or anything like that from the LS, I'll have them do another couple of weeks. So 4 to 6 weeks, so that's a lot in steroid world. And then I'll have them use the clobetasol on the weekends only, again, once or twice a day. And then I'll give them a steroid-sparing agent like tacrolimus for the weekdays. So yes, you always need maintenance with LS, I think. Eventually, some people are just on the steroid-sparing agent without the clobetasol, and I tell them to keep the clobetasol in their closet, and should they develop any symptoms, just go ahead and do another 2 weeks, and then go back to their tacrolimus. Okay, let me see. Anything in the Q&A portion, Kristen? Anybody put questions there that I missed?
I don't see anything. I think you grabbed them all. So thank you.
Okay.
It's always a
You're welcome.
pleasure to moderate these sessions, and it's fascinating. So thank you so much, Dr. Okoye. This was great. Thank you all for joining us today. And just a reminder that your CME survey will appear in a tab on your browser. Please get the correct date, June 21st, and the correct speaker, Dr. Okoye. And we have a comment that said, best derm lecture ever. And I agree. So
That made my day. Thank you. Thank you so much. And thanks for being engaged, everybody. That was fun.
All right. Have a great weekend, everyone, and we'll see you next time.
Bye.